Hello everyone. In this video we are going to discuss about a gynecology topic called abnormal uterine bleeding. Before knowing the abnormal types, we need to know the normal physiology of menstruation. You see the hypothalamus here releases gonadotropin releasing hormone. The gonadotropin releasing hormone acts on the anterior pituitary. Acting on the anterior pituitary, it releases follicle stimulating hormone and luteinizing hormone. Hypothalamus releases GnRH. The GnRH acts on the anterior pituitary and it releases FSH and LH. These two hormones, FSH and LH, will act on the ovaries. Acting on the ovary, they cause the maturation of the primary follicle into a mature Graafian follicle. Then, this mature Graafian follicle is going to secrete estrogen. The estrogen level is going to increase in the blood. Once there is an increase in the level of the estrogen, this results in the growth of the endometrium. You see the estrogen causing the growth of the endometrium here. Now, on the 14th day, the ovulation takes place. You see, 14th day ovulation takes place and the residue is known as corpus luteum. This residual corpus luteum is going to secrete progesterone and estrogen. The progesterone is more in quantity. It is going to secrete the progesterone. The estrogen is also maintained. The corpus luteum secretes progesterone only. Now the progesterone levels are going to increase and then there is a thickening and the secretory thickness of the endometrium. There is a thickening as well as the secretory changes in the endometrium. Then what happens if the fertilization does not occur? The corpus luteum is going to degenerate. This corpus luteum is degenerating here. As a result, the level of the estrogen and as well as the progesterone is reducing in the blood. This is resulting in the endometrial shedding. This happens and there is endometrial shedding happening. Hope it is clear. Physiology of menstruation is very important. The normal physiology to understand the abnormal types. So guys, we are going to again summarize. The hypothalamus is releasing GnRH. The GnRH is acting on the pituitary. FSH and LH is going to be released. The FSH acts on the ovaries, causes the maturation of the follicle. The mature follicle releases estrogen, which causes growth of the endometrium. Now what happened? Till now there is growth of the endometrium. Then you see on the 14th day ovulation is happening. There is rupture of the Graafian follicle. Then the remaining is corpus luteum. The corpus luteum is going to secrete a hormone progesterone. Then there is an increase in the level of progesterone. What happens? The endometrium is becoming more thick and secretory in activity. This is how becoming more thick it is preparing the endometrium for the implantation. Now it is waiting, the implantation doesn't occur. Then what happens? There is degeneration of the corpus luteum. Once there is degeneration of the corpus luteum, what happens? The estrogen progesterone levels falls and resulting in the endometrial shedding. Next, what happens? You see, the abnormal types we are going to discuss first, starting with menorrhagia. Menorrhagia is, the synonym is hypermenorrhea. For menorrhagia, the synonym, it is also known as hypermenorrhea. Menorrhagia is defined as a cyclic bleeding at normal intervals. So you see, in menorrhagia, the cycles are regular. If it is a 28-day cycle, it is constant. The cycles are regular. It is occurring at the normal intervals. The bleeding is either excessive in amount, more than 80 ml, or the duration is prolonged to more than 7 days, or both. Since the cycles are regular, what is the abnormality here? The bleeding is in excessive amount. It can be either 80 ml or the duration can be prolonged to more than 7 days. Then it is known as menorrhagia. The term menotaxis is often used to denote the prolonged bleeding. When the woman is having a prolonged bleeding, menotaxis is the term referred. Hope it's clear. What is menorrhagia, guys? When there is an excessive bleeding and the duration is prolonged to more than 7 days, but the intervals are regular. This is known as menorrhagia. The causes. For the causes of excessive bleeding, it can be either organic or functional. The organic causes, we are going to discuss the pelvic pathology. Pathology is the abnormality. What are the abnormalities found which are resulting in excessive bleeding? Due to congestion, there is increased surface area or hyperplasia of the endometrium. Because of the congestion, there is increase in the number of cells of the endometrium. There is hyperplasia of the endometrium. The other causes are First, fibroid uterus. You see fibroid uterus. What is fibroid uterus? It is a benign uterine tumor of the smooth muscle origin, that is from the myometrium. You see, this is a uterine tumor. Fibroid uterus is a benign localized uterine tumor. Adenomyosis, pelvic endometriosis. Adenomyosis is a condition where the endometrial tissue is growing in the muscle of the uterus, that is in the myometrium. Instead of growing in the endometrium, when the endometrium starts growing in the myometrium, the invasion of the endometrium into the next layer, that is myometrium, this is known as adenomyosis. Then we come to endometriosis. When the endometrium grows outside the uterus, which may involve the ovaries or the fallopian tubes or the peritoneum, that is termed as endometriosis. You can see in the picture here, the endometrium, instead of growing here, if it starts growing in the ovaries or the fallopian tube, then that is known as pelvic endometriosis. IUCD in utero, intrauterine contraceptive devices which are placed inside the uterus, that could be either hormonal IUD or copper IUDs, copper T, popularly copper T. Chronic tubo-ovarian mass. The chronic tubo-ovarian mass, it is an infectious mass of adnexa. Adnexa, the ovaries and the fallopian tubes, sometimes the ligaments together, they are called as adnexa. When there is an infectious mass formed, as a result of the pelvic inflammatory diseases, this will result in the formation of a chronic tubo-ovarian mass. The tubes and the ovaries, there is a mass formation. Tubercular endometritis. You see, tubercular. It is caused by Mycobacterium tuberculosis. Once from the lungs, it could be secondary from the lungs or the PID. This will result in genital tuberculosis. The genital tuberculosis can in turn result in tubercular endometritis. Retroverted uterus. Retroverted uterus, what happens here? The uterus is tilted backwards. Rather than being forward, it is tilted backwards. This can result in endometriosis, which in turn can result in menorrhagia. Granulosa cell tumor of ovary. What is granulosa cell tumor of ovary? It is a benign tumor. It is originating from the sex cord or the stromal cells of the ovary. You can see the ovary. From the stromal cells of the ovary, the cancerous tumor is originating from the stromal cells of the ovary. This is known as granulosa cell tumor. This tumor is going to produce large amount of estrogen. When there is an excess amount of estrogen, this will result in excessive growth of the endometrium. Once there is excessive growth of the endometrium, the shedding is also going to be more, excessive bleeding occurs. Hope the organic causes are clear. Now we will see the systemic causes and the endocrinal causes. Systemic liver dysfunction failure to conjugate and thereby inactivate the estrogen. When there is hormonal imbalance, when the liver is going to fail to regulate the production and the breakdown of the estrogen, there is inactivation and thereby inactivates the estrogen. Congestive cardiac failure, severe hypertension can also be the cause for menorrhagia, excessive bleeding. Endocrinal, the hypothyroidism, hyperthyroidism. What happens in the endocrinal cases? Once there is increase in the TSH level, TSH level, that is thyroid stimulating hormone, there is more prolactin released, there is hyperprolactinemia. This prolactin is going to inhibit the secretion of FSH and LH. Then this results in estrogen, excess of estrogen. No inhibition effect won't be there. Then FSH and LH is going to be released in excess amount, which will result in menorrhagia. So guys, what happens basically in hypothyroidism? Again, there is alteration in the hormonal level. The TSH levels, the estrogens, progesterone, all hormonal levels are affected in thyroid people, which results in the menorrhagia. Now we see hematological disorders. Hematological disorders such as idiopathic thrombocytopenic purpura, leukemia, platelet deficiency, von Willebrand disease. What happens in these cases? There is low platelet count. Once the platelet count is reduced, there will be absence of localization of the platelets to the bleeding site. Either there will be absence or there won't be absence. Since it is low, there is low accumulation of platelets to that site, resulting in increased bleeding time. the bleeding is going to prolong for more time. There is excessive bleeding since the platelet count is low, and they wait for the regeneration to occur on its own. They do not go and cause the platelet plug formation, and they do not cease the bleeding. It occurs for a longer period. That is why the hematological causes are given. Now we see the functional causes. We saw hypothalamo-pituitary ovarian axis. Whenever there is a disturbance in this HPOA axis, this results in menorrhagia. Either the GnRH, FSH, LH or the estrogen levels. Whenever there is an abnormality in the estrogen progesterone levels, this will result in menorrhagia. Now we see the common causes of menorrhagia. Dysfunctional uterine bleeding. The dysfunctional uterine bleeding, either it could be in the form of primary DUB or secondary DUB. Primary DUB, it is irregular acyclic bleeding without any iatrogenic, organic or systemic cause. Secondary, there could be a problem in the HPOA axis, that is hypothalamo-pituitary ovarian axis. So DUB can be a common cause. Fibroid uterus, we have discussed. Adenomyosis, chronic tubo-ovarian mass, it is just a revision again. DUB is the new one here. Now we move on to the diagnosis. How do you diagnose it to be the menorrhagia? You need to see the long duration of flow, that is more than 7 days. If there are any passage of big clots, or the use of increased number of thick sanitary pads. When the woman is using more than 7 sanitary pads in a day. Pallor, that is paleness seen in a patient, and low level of hemoglobin. When you ask the patient to get her hemoglobin done, it is going to be really low. Then it gives an idea about the correct diagnosis and the magnitude of menorrhagia. When the woman is pale and her hemoglobin level is low, she is using more number of thick sanitary pads, the duration is prolonged, and there is big clots found, then this is known as menorrhagia. This is how you are going to diagnose the menorrhagia. Now we'll see the polymenorrhea. The synonym for polymenorrhea is epimenorrhea. Polymenorrhea is defined as a cyclic bleeding where the cycle is reduced to an arbitrary limit of less than 21 days and it remains constant at that frequency. So guys, polymenorrhea, many times the menses happen. So there is an increased cycles of menses. It is less than 21 days, and it is remaining constant at that frequency. If the frequent cycle is associated with excessive or a prolonged bleeding, along with the cycle being reduced to less than 21 days, during that cycle, if the bleeding is excessive and the bleeding phase is going to be prolonged, then this is known as epimenorrhea. So guys, if the bleeding is reduced to less than 21 days, when the bleeding less than 21 days, on top of it there is excess bleeding and the duration of the bleeding is prolonged, this is epimenorrhea. This is the difference. Polymenorrhea, synonym is epimenorrhea. Both are one and the same. When it is less than 21 days and it is occurring with excessive bleeding and prolonged bleeding. Hope polymenorrhea is clear. Now we are going to see the causes for the excessive bleeding, prolonged duration, and when it is reduced to less than 21 days. What is the cause? It is predominantly seen during adolescence. Adolescents are the people from 18 to 24 years of age, preceding the menopause and following the delivery and abortion. So the polymenorrhea is found in people of adolescence age preceding the menopause, just before menopause and following the delivery and abortion. Hyperstimulation of the ovary by the pituitary hormones. So there is hyperstimulation of ovary. We saw in the normal physiology of menstruation, the pituitary hormones, that is FSH and LH, are going to be released. These hormones, FSH, is going to act on the ovary and cause the maturation of the primary follicle to Graafian follicle. This is the normal physiology. When there is hyperstimulation of the ovary by the pituitary hormones, this will be the cause for the polymenorrhea. Ovarian hyperemia, as in pelvic inflammatory disease or ovarian endometriosis. You see, whenever there is ovarian endometriosis, when the endometrium, instead of growing in the endometrial tissue, if it starts growing in the ovary, then it is known as ovarian endometriosis. And pelvic inflammatory diseases, this could be the causes for polymenorrhea. Now we see menorrhagia. What is menorrhagia? Menorrhagia is an irregular acyclic bleeding from the uterus. So the cycles are irregular here. There we knew it was less than 21 days in polymenorrhea, but in menorrhagia we do not know. It is irregular and acyclic bleeding. Amount of the bleeding is variable, while menorrhagia strictly concerns uterine bleeding. But in clinical practice, the bleeding from any part of the genital tract is included under the heading. If it is from the vaginal bleeding, cervical bleeding, any part of the genital tract, it is considered to be not only from the uterus, even if it is from the cervix and vagina and everything, it is considered to be menorrhagia in the clinical practice. Then again, irregular bleeding in the form of contact bleeding or intermenstrual bleeding in otherwise normal cycle is also included in menorrhagia. See guys, if the cycles are normal, but during the intermenstrual from one cycle to another cycle if there is bleeding, and in case of contact bleeding, we are going to see in detail in the next slides the contact bleeding, the causes for everything. If it is in the form of contact bleeding or during the intermenstrual bleeding, this is also termed as menorrhagia. What is menorrhagia? The irregular acyclic bleeding. It is normal. It is not normal here. During menses, if the bleeding occurs, it is normal. If it is occurring during the period, intermenstrual period, or in the form of contact bleeding irregularly, then it is known as menorrhagia. Irregular and acyclic. In fact, it is mostly related to the surface lesion of uterus. Mostly it is the lesion of the uterus. But in some cases, the other things can also be involved, which will lead to intermenstrual bleeding and contact bleeding. Now we are going to see the causes in detail. The causes for intermenstrual bleeding, that is from one menses to one menses, the period between it is known as intermenstrual period. If the bleeding occurs during that period, what are the causes for it? Apart from the causes of contact bleeding, the other causes could be the urethral caruncle. You see the urethral caruncle, it is a fleshy outgrowth which is found on the posterior urethral meatus. It is a benign lesion. It is a localized lesion. It is a fleshy growth which is found on the posterior urethral meatus. So it is in the intermenstrual bleeding. It is not occurring from the uterus. The posterior urethral meatus, urethra, you can see the, you have to imagine the urinary tract, the urethra, there is a fleshy growth there which is causing the bleeding, but it is coming from the genital tract. So any bleeding from the genital tract is considered to be menorrhagia. Breakthrough bleeding in pill use. So with the people who use oral contraceptive pills, there is a breakthrough bleeding. They do not want menses, but there is a breakthrough bleeding in the pill use. IUCD in utero, we saw the intrauterine contraceptive devices can also result in intermenstrual bleeding. Ovular bleeding. Decubitus ulcer. The ovular bleeding can occur. And decubitus ulcer. The decubitus ulcers are the bed sores. They can turn out to be cancerous and then result in bleeding. The intermenstrual bleeding, these are the causes. Now we'll see the causes for the contact bleeding. Carcinoma cervix, the cancer of the cervix. Mucus polyp of the cervix. Guys, polyps are the non-cancerous growths which are attached to the inner walls of the cervix. When these non-cancerous growths, there is proliferation of excess of cells. When the cells, overgrowth of the cells occur in the cervix, the mucus polyp of the cervix. Vascular ectopy of the cervix. You see ectopic pregnancies, what happened? The ectopic pregnancy can happen. Instead the fetus, instead of growing in the uterus, it starts growing in the cervix. The implantation takes place there. Then the blood supply happens. Vascular ectopy of the cervix, which can result in bleeding, contact bleeding, especially during pregnancy. Pill use cervix. Infections such as chlamydial and tubercular cervicitis. You see the genital TB, tubercular cervicitis, which is affecting the cervix. Then there could be contact bleeding. Cervical endometriosis, when the endometrium is growing in the cervix, which can also be a reason for contact bleeding. So guys, that's carcinoma of the cervix, cervical endometriosis, mucus polyp of the cervix, vascular ectopy of cervix, all for cervix, and then infections of the chlamydial, or infections could be in the form of chlamydial or tubercular cervicitis. Hope it is clear. Cancer, polyp, endometriosis of cervix, ectopy of cervix, and the infection of cervix. Now we see the causes for the acyclic bleeding. What could be the causes for the acyclic bleeding? The DUB, we have discussed DUB. It occurs during adolescence, following the childbirth and abortion, and preceding the menopause. We saw DUB could be either in the form of primary DUB or secondary DUB. DUB is the dysfunctional uterine bleeding, abnormal. Dysfunctional uterine bleeding, it is primary or secondary. Primary is because of it occurs without any unknown organic, systemic or iatrogenic cause, whereas the secondary DUB, if there is any abnormality or dysfunction of the HPOA axis, that is hypothalamo-pituitary ovarian axis. Now you see the submucous fibroid, the fibroids, the uterine polyps, carcinoma cervix and endometrial carcinoma can be a cause of acyclic bleeding. You see, acyclic bleeding, most probably the uterus is involved. Dysfunctional uterine bleeding, uterus, submucous fibroid, uterine polyp, carcinoma cervix and endometrial carcinoma. These could be the causes of acyclic bleeding. Now we see the summarization of menorrhagia. Menorrhagia, it could be in the form of intermenstrual bleeding, acyclic bleeding, contact bleeding, intermenstrual, urethral caruncle, breakthrough bleeding in pill, IUCD in utero, ovular bleeding, decubitus ulcer. Acyclic, DUB, fibroid, polyp, carcinoma cervix, endometrial carcinoma. Contact, there is carcinoma of the cervix, the polyp of the cervix, vascular ectopy of cervix, infection of the cervix and cervical endometriosis. Now we move on to oligomenorrhea. Oligomenorrhea, when the menstrual bleeding is occurring more than 35 days apart and it is remaining constant at that frequency, it is called oligomenorrhea. Oligo is scanty, less, few. So oligomenorrhea, it happens more than 35 days apart. So obviously the cycles are reduced in number. It is occurring more than 35 days apart. This is oligomenorrhea. The common causes for oligomenorrhea, for the menstrual cycle to be prolonged for more than 35 days, what are the causes? If it is age related, it is during the adolescence and preceding the menopause. If it is weight related, it is due to obesity. Obesity can cause a change in the hormonal levels, which will result in oligomenorrhea. Stress and exercise related. When there is an excessive weight gain or excessive weight loss via exercise, if they are losing excessive weight, that can also cause a hormonal imbalance in the body, resulting in oligomenorrhea. Endocrinal disorders such as PCOS, polycystic ovarian syndrome, which is the commonest cause for oligomenorrhea. Hyperprolactinemia, hyperthyroidism. As we discussed earlier, hyperthyroidism, the follicle stimulating hormones, there is increased prolactin level. Once the prolactin levels are increased, they are going to inhibit the FSH and LH. By inhibiting the FSH and LH, estrogen won't be released, so endometrial growth does not happen and oligomenorrhea. This happens here. Hyperprolactinemia, again, no FSH, LH, no endometrial growth, so oligomenorrhea. Androgen producing tumors such as ovarian and adnexal, they can also be a cause for oligomenorrhea. Androgen producing tumors. Tubercular endometritis in the late cases. Drugs such as phenothiazins, cimetidine, methyl dopa can also be the cause for oligomenorrhea. You see guys, age related was adolescence and menopause. Weight related, obesity, stress, exercise. Endocrine disorders were PCOS, hyperprolactinemia and hyperthyroidism. Then we saw the androgen producing tumors such as ovarian and adrenal can also be a cause for oligomenorrhea. Tubercular endometritis and the drugs such as phenothiazins, cimetidine and methyl dopa. Now we are going to discuss about hypomenorrhea. Oligo is more than 35 days apart. Hypomenorrhea, when the bleeding is scanty and it is lasting for less than 2 days. When the bleeding phase is less than 2 days and the quantity is very scanty and the duration is less than 2 days, it is hypomenorrhea. You can see in the picture here, they defined as a blood loss of less than 30 ml per period. Every period, if the bleeding is less than 30 ml and it is lasting for less than 2 days, that is 1 day or half a day or few hours, then it is hypomenorrhea. The causes for oligomenorrhea are Local are uterine sync or endometrial tuberculosis, uterine sync Asherman syndrome, or endometrial tuberculosis. You see the tuberculosis which is occurring in the lungs in the secondary, as a secondary TB. It can occur via the hematogenous spread or the lymphatic spread. It can affect the genital tract, resulting in endometrial tuberculosis. Endocrinal, use of oral contraceptives, thyroid dysfunction, premenopausal period. See guys, the people who are reaching the menopause, there is cessation of menstruation in menopause. So just before the menopause, there is going to be oligomenorrhea. They are going to have menses either for 1 day or 2 days with a gap of 3 to 4 months. This is normal. Premenopausal period could be a cause for oligomenorrhea. Systemic malnutrition, if the person is malnutrition, there is she will be anemic. Since she is anemic, no blood, no hemoglobin, no RBCs, no bleeding. Dysfunctional uterine bleeding, very important, we are going to discuss in detail. Dysfunctional uterine bleeding is defined as a state of abnormal uterine bleeding without any clinically detectable organic, systemic or iatrogenic cause. So there is no clinically detectable systemic, iatrogenic or organic cause, but there is an abnormal uterine bleeding. So bleeding occurs abnormally, uterine bleeding is happening, but we do not find any detectable organic, systemic or iatrogenic cause. The pelvic pathology, example the tumor, inflammation or pregnancy, is excluded. Heavy menstrual bleeding, it is defined as bleeding which will interfere with the woman's physical, emotional, social and maternal quality of life. When the bleeding is going to interfere with the bodily, mentally, social and maternal quality of the women, this is heavy menstrual bleeding. The incidence of dysfunctional uterine bleeding, the prevalence varies widely, but an incidence of 10% among the new patients attending the outpatient seems logical. So the 10% is seen among the new patients, which are OPD patients. 10% is DUB. The bleeding may be abnormal in frequency, in amount, duration, or the combination of any three. You can see the frequency of the cycles, there is an abnormality. The amount, the quantity, 30 ml, 80 ml, the amount is going to vary. The duration, if the bleeding is occurring for 3 days, 5 days, 7 days, more than 7 days and everything, or there could be a combination of all three. Currently, the dysfunctional uterine bleeding is defined as a state of abnormal uterine bleeding following an ovulation. So, DUB, dysfunctional uterine bleeding, occurs following the anovulation. Ovulation does not occur, resulting in DUB due to the dysfunction of hypothalamo-pituitary ovarian axis. So guys, in the normal physiology of menstruation, we read that the hypothalamus has to secrete GnRH, it has to act on the anterior pituitary, release FSH and LH. Whenever there is a disturbance in the hypothalamo-pituitary ovarian axis, an ovulation occurs. Ovulation does not take place since estrogen won't be released properly, so the ovulation does not occur, corpus luteum not released. Everything is abnormal here, resulting in DUB. Whenever there is an abnormality in HPOA axis, there is an ovulation. Now you see, the abnormal bleeding may be associated with or without ovulation, accordingly grouped into. So the abnormal bleeding may be occurring without ovulation or with ovulation. If it is occurring with ovulation, it is there are three subheadings: polymenorrhea, oligomenorrhea, functional menorrhagia. We saw polymenorrhea, oligomenorrhea already. We are going to discuss functional menorrhagia in detail and what is the pathophysiology of polymenorrhea and oligomenorrhea. Then we see in the anovular bleeding, it is menorrhagia, excessive bleeding, cystic glandular hyperplasia. We are also going to discuss about cystic glandular hyperplasia. So ovular is poly, oligo and functional. Anovular is menorrhagia and cystic glandular hyperplasia. Ovular bleeding, there were three headings. First one was polymenorrhea. Polymenorrhea, also known as polymenorrhagia. The condition usually occurs following the childbirth or abortion, during adolescence, premenopausal period or in PID, pelvic inflammatory diseases. So we know the polymenorrhea is found in adolescent girls, premenopausal period, following the delivery or childbirth, and also in PID. The follicular development is speeded up, resulting the shortening of follicular phase. So guys, polymenorrhea, excessive bleeding is menorrhagia. Polymenorrhea, it is occurring less than 21 days. Why less than 21 days? It is because the follicular phase, where there is maturation of the primary follicle into Graafian follicle, there is speeding up. The primary is being matured into the Graafian follicle real fast, so it is going to be speeded up. This will result in the shortening of the follicular phase. As a result, this results in the shortening of the cycle as well. This is probably due to the hyperstimulation of the follicular growth by FSH. When does the follicular growth speed up? When there is a hyperstimulation by the follicle stimulating hormone. When the name itself specify, guys, follicle stimulating hormone, it is stimulating the follicles to mature. When there is hyperstimulation by the FSH, it is going to shorten the shorten this phase, follicular phase, resulting in polymenorrhea. Rarely, the luteal phase may be shortened due to premature lysis of the corpus luteum. Sometimes it is related to stress-induced stimulation. So even the luteal phase can be affected rarely because the degeneration of the corpus luteum is occurring at a faster rate, which results in the lower levels of the estrogen and progesterone. Fall happens, the estrogen and progesterone hormone levels are going to fall early, and which will result in shedding. Hope the polymenorrhea is clear. What you need to remember in polymenorrhea, there is a shortening of follicular phase, and also there is hyperstimulation of follicular growth by FSH. Then we move on to oligomenorrhea. Primary ovular oligomenorrhea is rare. It may be met in adolescence and preceding menopause. Oligomenorrhea is also met in adolescence and preceding the menopause. The disturbance is due to ovarian unresponsiveness to FSH. What happens in oligomenorrhea? The cycle is increased to a duration of more than 35 days apart, and it is remaining constant at that frequency. This is what we read in oligomenorrhea's definition. Why does this cycle is prolonged? It is because the ovaries are unresponsive to FSH, or it is secondary to pituitary dysfunction. Or if the pituitary dysfunction and the FSH is not released, either the FSH is not released or the ovaries are unresponsive to FSH, either of the cause can be for oligomenorrhea. There is undue prolongation of the proliferative phase with the normal secretory phase. So there is a prolongation of the proliferative phase. The primary becoming a Graafian follicle, it is taking a long time because FSH is not released properly, or the ovaries are unresponsive to FSH. Hence the proliferative phase is prolonged and the normal secretory phase. Now we see the functional menorrhagia. Ovular menorrhagia is quite uncommon. The two varieties are found. In functional menorrhagia, you can find two varieties. Either there is irregular shedding of the endometrium, or it could be irregular ripening of the endometrium. You see guys, there is irregular shedding or irregular ripening. Why does the ripening happen? Because of the poor formation and inadequate function of the corpus luteum. Since there is inadequate corpus luteum, then there will be inadequate estrogen and progesterone. The corpus luteum is going to secrete less progesterone. So the support to the endometrial growth is reduced, and the slight bleeding will occur prior to the start of the flow. What happens in functional menorrhagia? Irregular ripening of endometrium. How does it get riped? The corpus luteum is absent, progesterone, estrogen is absent, the endometrial support is not there, which is resulting in bleeding. Hope functional menorrhagia is clear. Two things happen: irregular shedding and irregular ripening of the endometrium. Now we move on to the second half of the DUB, anovular bleeding. There were two subheadings, menorrhagia and cystic glandular hyperplasia, Metropathia hemorrhagica. The synonym for it is. Now we are going to discuss about menorrhagia. Anovular bleeding is usually excessive. So the anovular bleeding, ovulation is not occurring here, so the bleeding is very excessive. How? In the absence of growth limiting progesterone, Guys, after the ovulation occurs, there is rupture of Graafian follicle and the residue is corpus luteum, which is secreting progesterone. Now, since the ovulation is not happening, corpus luteum won't be formed. So the progesterone also will not be there. In the absence of the growth limiting progesterone due to anovulation, the endometrial growth is under the influence of estrogen throughout the cycle. Since there is no progesterone, only the endometrium is only under the influence of estrogen. Endometrium is only under the influence of estrogen. So there is inadequate structural stromal support and the endometrium remains fragile. Since there is no progesterone and no estrogen level is high, but there is no progesterone, the stromal support won't be there and the endometrium will become fragile. Thus, with the withdrawal of estrogen due to the negative feedback action of FSH, what happens after a certain period of time, the FSH, there is a negative feedback. The FSH, follicle stimulating hormone, is going to give a negative feedback to the pituitary to stop the release of the estrogen. Since there is a negative feedback by the FSH to the pituitary, the endometrial shedding continues for a long period. And now there is a shedding starts and it is going to continue for a long period. Hope it is clear what happens in ovular bleeding. There are two subheadings, menorrhagia and cystic glandular hyperplasia. In menorrhagia, what happens? There is absence of progesterone. Since there is absence of progesterone, endometrium only under the influence of estrogen, no structural stromal support, so the bleeding is heavy. Cystic glandular hyperplasia. The synonym is Metropathia hemorrhagica, Schroeder's disease. This type of abnormal bleeding is usually met in premenopausal women. So, Metropathia hemorrhagica is found in premenopausal women. The basic fault may lie in ovaries or due to the disturbance of rhythmic secretion of gonadotrophins. So, for the Metropathia hemorrhagica to occur, there must be fault in the ovary. For Metropathia hemorrhagica, either there is a fault in the ovary or there is a disturbance of secretion of GnRH. There is slow increase in secretion of estrogen but no negative feedback inhibition of FSH. So what happens? There is no proper secretion of GnRH, so it does not stimulate the pituitary properly. FSH release secretion will be low. So there is slow secretion of estrogen. Even the estrogen levels won't be normal. There is slow increase in the secretion of estrogen but no negative feedback inhibition to FSH. But it does not give any negative feedback inhibition to the FSH. The net effect, when there is no negative feedback, what happens? The pituitary goes on releasing FSH and FSH goes on releasing estrogen. The net effect is a gradual rise in the level of estrogen. With the concomitant phase of amenorrhea, there is a concomitant phase of amenorrhea for about 6 to 8 weeks. So guys, in cystic glandular hyperplasia, either there is a fault in the ovary or there could be a disturbance in the gonadotrophin releasing hormone. Then what happens? There is a slow secretion of FSH, slow increase in estrogen level but no negative feedback. So there is an increase in the estrogen level resulting in Metropathia hemorrhagica, and along with that there is going to be amenorrhea for 6 to 8 weeks. As there is no ovulation, the endometrium is only under the influence of estrogen without being opposed by growth limiting progesterone. We have already discussed, whenever there is no ovulation, corpus luteum formation won't be there and progesterone won't be released. Since there is no progesterone, endometrium is only under the influence of estrogen for a prolonged period. After a variable period, the estrogen level falls, resulting in endometrial shedding with a heavy bleeding. What happens in cystic glandular hyperplasia? There is no progesterone. The endometrium is only under the influence of estrogen. So endometrial thickening growth happens for a long period, resulting with heavy bleeding. Due to the increased endometrial thickness, see, there is endometrial thickness, tissue breakdown will continue for a long time. Bleeding is heavy as there is no vasoconstrictor effect of PGF2 alpha. Now from where did this PGF2 alpha come? PGF2 alpha is the prostaglandin factor 2 alpha which is released by the progesterone. You see, there is no ovulation happening, no corpus luteum, so no progesterone. The progesterone, under the action of progesterone, this prostaglandins are released. This prostaglandins will act as a vasoconstrictor. Here the bleeding is heavy because there is no vasoconstrictor effect of PGF2, no progesterone, so no prostaglandin, so vasoconstriction is not happening. As a result, the bleeding will be prolonged until the endometrium and the blood vessels will regenerate on its own to control it. So there is no vasoconstrictor effect. The blood vessels have to regenerate on its own, so it is going to take a long time and the endometrial shedding is going to be very heavy. Now we'll see the changes which are happening in the uterus. There is a variable degree of myohyperplasia. You can see the changes happening in the uterus in dysfunctional uterine bleeding. The endometrium, the myometrium. There is increase in the uterine size along with the myohyperplasia. Hyperplasia is the increase in the number of cells of the myometrium. So guys, myometrium, the outer layer of the endometrium, the myometrium is going to increase in the size. With the symmetrical enlargement of the uterus to a size of about 8 to 10 weeks, even the uterus is going to increase in the size simultaneously up to a size of 8 to 10 weeks pregnant women, up to a pregnant uterus, up to that size the uterus is going to enlarge due to the simultaneous hypertrophy of the muscles. Along with that, there is a simultaneous hypertrophy of the muscles of the uterus. Endometrial changes are classical. Now we move on to the endometrial. Endometrial changes will be classical. On the naked eye examination, the endometrium will look thick, congested and often polyploidal. Polyploidal is they contain multiple polyps. Multiple polyposis can be seen. Now we'll see microscopically how do you diagnose it to be DUB. There is a marked hyperplasia of all the endometrial components. You can see the endometrium here. There is a marked changes of all the components of the endometrium. There is, however, intense cystic glandular hypertrophy rather than hyperplasia. So there is increased intense hypertrophy rather than the increase in the number of cells. There is hypertrophy with a marked disparity in sizes. You can see there is disparity in sizes. There are differences in the sizes. Some of the glands are going to be small. The others are going to be large, giving the appearance of Swiss cheese pattern. You can see the cheese which is found in Switzerland. It is popularly known as Swiss cheese, which contains small and large holes. So this pattern is given the nickname as a Swiss cheese pattern. Why is it called a Swiss cheese pattern? It is because the glands are either small and some of them are large. There is disparity in the sizes of the glands. These glands are empty and they are lined by columnar epithelium. You can see the picture here. It looks like a Swiss cheese. These glands, they are empty, they are small, they are large in number and they are lined by columnar epithelium. Absence of secretory changes. We are seeing the changes in the uterus. So the endometrium, there is absence of the secretory changes since it is only under the influence of estrogen. So secretory changes does not occur. Areas of necrosis in the superficial layer and with small hemorrhages and leukocytic infiltration. Necrosis, there is death of cells in the superficial layers of the uterus with the small hemorrhages and the leukocytic infiltration. Now we'll see the changes in the ovary. What changes take place in the ovary in dysfunctional uterine bleeding? Cystic changes may be observed involving one or both the ovaries. The cyst may be single or multiple and the fluid contains estrogen. The cyst which contains fluid in it, the fluid is going to contain estrogen. The cyst can be either in one ovary or in both the ovaries. You see polycystic, either in one or both the ovaries. You can see the cyst formation. The cyst is going to contain fluid which contains estrogen. The cyst is of follicular type. There is no evidence of corpus luteum. Now we are going to see another change which is happening. There is atrophy of the endometrium. Atrophy is the reduction in the size of the endometrium. This type of abnormality is commonly met in the postmenopausal women. You see there is atrophy of the endometrium. Atrophy can also result from the disuse of the uterus. When there is the woman is not using the uterus either for implantation or menses is not happening. Nothing is happening in the postmenopausal women. The uterus is not in use. So this type of abnormality, atrophy of the endometrium, it is common in postmenopausal women, but it can occur in the reproductive period. The atrophy is not supposed to occur in the reproductive period, but it is occurring in reproductive period as a final involutionary state of previous metropathia. Whenever the person has suffered from the metropathia as a final involutory state, the atrophy of the endometrium can take place. The bleeding occurs from the rupture of the dilated capillaries beneath the atrophic surface epithelium. We saw in the endometrial lining there was necrosis, there were small hemorrhages. From where does this hemorrhage happen? From the rupture of the dilated capillaries which are in the beneath the surface epithelium of the atrophied endometrium. Beneath them there is a capillaries which are dilated, resulting in hemorrhage. The cause of the endometrial atrophy may be due to total absence of estrogen. The atrophy of endometrium can occur because of the absence of estrogen totally, or failure of the uterine receptors to become responsive to estrogen. Either there is absence of estrogen, or the uterine receptors or the endometrium is becoming unresponsive to estrogen. Because of these two causes, there is atrophy of endometrium: absence of estrogen or unresponsive of the endometrium to estrogen. Now we are going to look into the investigations in detail, the different procedures used to diagnose. History. Firstly, it is to be confirmed that the bleeding is through the vagina and not from the urethra or rectum. We need to confirm that the bleeding is from the vagina and not from the rectum or elsewhere, urethra, and so on. The statement of excessive bleeding is assessed by: how do you conclude it to be excess bleeding? When the number of pads used are more than 7 per day. The passage of clots, the size and the number should be investigated. The duration of the bleeding should also be asked. So in the investigations, first you are going to rule out that the bleeding is only from the vagina and not from the urethra or the rectum. Then you are going to ask, to conclude it to be excessive bleeding, you need to ask how many pads she uses, the clots are found, the size and the number, and the duration of the bleeding. The special investigations, CBC if she is anemic. Hemoglobin estimation is done in every case. In pubertal menorrhagia, platelet count, prothrombin time, partial thromboplastin time, bleeding time should be estimated. We saw the causes. In the causes there was blood disorders such as von Willebrand factor, idiopathic thrombocytic purpura. In all these cases it could be a cause, so we need to find out the platelet count, the prothrombin time, thromboplastin time, and the bleeding time. In suspected cases of thyroid dysfunction, in these cases of the thyroid dysfunction, you need to know the serum thyroid stimulating hormone levels. The T3 and T4 levels are to be estimated. So guys, we knew that in the causes, we read that in the endocrinal causes, because of the thyroid patients, there will be increased prolactin level, FSH and LH will be inhibited, resulting in so many disorders. So we need to know the thyroid. If the person is having thyroid, we need to know the serum TSH, T3, T4 levels. Now the procedures: TVS, transvaginal sonography, and color Doppler. TVS, transvaginal sonography, is very sensitive to detect any anatomical abnormality. So TVS is going to detect any of the anatomical abnormality. You can see they are going to detect the transvaginal sonography here. By inserting this device, they can see the abnormality there on the computer. There is they detect any anatomical abnormality, that is fibroid and adenomyosis of the uterus, endometrium, and adnexae. Adnexae, I have already told you, it is the ovaries and the fallopian tubes and also the ligaments which support the ovaries. Ultrasound and color Doppler. Color Doppler findings of endometrial hyperplasia are: to conclude that the endometrium is hyperplaced, that is, there is thickness of the endometrium should be more than 12 mm. Hyperplasia is increase in the number of cells of the endometrium, which is increase in the size of the endometrium. How do we conclude that? When the endometrial thickness is more than 12 mm, there is hyperechoic and regular outline. Angiogenesis and neovascular signal study. When there is new blood vessels formed, angiogenesis and neovascular signal study. Saline infusion sonography, SIS. It is found very helpful to diagnose the endometrial polyps, submucous fibroids, and uterine abnormality. So you can diagnose the endometrial polyps, fibroids, and any other uterine abnormality, that is the septate uterus or subseptate uterus. If the uterus is either septate or subseptate, these can be diagnosed by saline infusion sonography. Hysteroscopy, it is done for the better evaluation of endometrial lesion and to take the biopsy from the offending site under direct vision. Hysteroscopy, there is a plus point. Both the endometrial lesion can be evaluated, along with that the biopsy can be taken then and there, and there is a direct vision. The frequent findings of polyp, submucous fibroid are often missed by blind curettage. If you do some blind curettage, we often miss the polyps and submucous fibroid. By hysteroscopy, you can do the better evaluation of the endometrial lesions, and we can also take the biopsy under our direct vision. You can see the hysteroscopy here. Endometrial sampling, it can be done as an outpatient basis. Pipelle sampler is easy to use. As it is a blind procedure, intrauterine pathology such as polyps, submucous fibroids cannot be detected. You see, endometrial sampling, it is a blind procedure. If you take a sample of the endometrium where there is no abnormality, then it is not going to help you. The endometrial sampling, it is a blind procedure. So the intrauterine pathology inside the uterus, it cannot reach that deep. Even if it reaches, if you take some other sampling, then it is of no use. The polyps and submucous fibroids cannot be detected by endometrial sampling. Now we see in the laparoscopy to exclude the unsuspected pelvic pathology such as endometriosis, pelvic inflammatory diseases, or ovarian tumor, granulosa cell tumor, that is the cancerous tumor from the stromal cells of the ovary. To exclude these pelvic inflammatory diseases, endometriosis, granulosa cell tumor, to exclude these pelvic pathology, laparoscopy can be done. The indication is urgent if it is associated with pelvic pain. If the patient is coming with these pathological conditions along with the associated pelvic pain, laparoscopy should be indicated. Diagnostic uterine curettage, DNC. Diagnostic uterine curettage is indicated in dysfunctional uterine bleeding. We have three things. To exclude the organic lesions in the endometrium. So in dilatation and uterine curettage, what happens? We exclude the organic lesions, incomplete abortion, endometrial polyps, tubercular endometritis, endometrial carcinoma can be excluded. To determine the functional state of the endometrium. What is the functional state? How is the functional state of the endometrium? To have an incidental therapeutic benefit. So by doing DNC, if the person was told to do DNC, but you find any pelvic abnormality, if you find any organic lesion, it can be a incidental therapeutic benefit for you. They were not hoping that they would have some fibroid or something like that, but if the DNC was done and incidentally you found out a fibroid and you treated it, then it could be an incidental therapeutic benefit. Management. The general rest is advised during the bleeding phase. You need to advise the rest for the patients during the bleeding phase. Ask them to be in rest. Assurance and sympathetic handling are helpful. So we need to give assurance to the patients. Sympathetic handling, particularly in the adolescents. So the adolescents, the young girls who are aged 18 to 24, they'll be having a lot of anxiety, they'll be worried about their disease. So the sympathetic handling to the adolescent girls. Anemia should be corrected energetically by diet. So if the patient is anemic, by giving them good diet plans, we need to increase their hemoglobin levels. Hematinics, and even by blood transfusion. In extreme cases, if the patient is too pale, too anemic, then we need to give them blood transfusion. The blood has to be transfused. Clinically evident systemic or endocrinal abnormalities should be investigated and treated accordingly. We saw endocrinal abnormalities, hyperthyroidism, hypothyroidism. All such cases we need to investigate and treat them accordingly. Abnormal vaginal bleeding. So guys, so far we read about abnormal uterine bleedings. Now we see there is an abnormal vaginal bleeding. In which cases the abnormal vaginal bleeding occurs? First, there is abnormal uterine bleeding. We are going to summarize. The organic causes were uterine fibroid, endometriosis, adenomyosis, endometrial polyps, IUCD in utero, adnexal pathology, that is tubo-ovarian mass. Hematological and endocrinal disorders, there were platelet deficiency, leukemia, idiopathic thrombocytic purpura, von Willebrand disease, and endocrinal disorders were the thyroid dysfunctions, hypothyroidism and hyperthyroidism. With this, we come to an end of abnormal uterine bleeding. Then we come to the abnormal vaginal bleeding, non-menstrual bleeding. So apart from the menses, when the bleeding occurs from the vagina, this is non-menstrual bleeding. If there is any foreign body present, urethral caruncles. We have already read, it is a weaning fleshy growth which is found on the posterior urethral meatus, the urethral caruncles, the genital malignancy, cancer of the genital tract, cervix, vagina or whatever, the genital malignancy, postcoital, there can be the vaginal bleeding, intermenstrual bleeding, abortion, breakthrough bleeding, the pill use. So with this, we come to an end of abnormal vaginal bleeding and also the chapter abnormal uterine bleeding. Thank you. If you have any doubts, you can put it down in the comment section. I'll try my best to solve them. If you like my video, hit the like button and subscribe to my channel. Thank you.